All right. Good afternoon, everyone. Thank you so much for joining us for this last closing plenary session of Positive Impact 2021. For this closing plenary, we have Tim Jackson from AIDS Foundation Chicago, um, who has been doing a lot lately. Who has been doing a lot of work. Yeah, just a little bit. Um, so I would like for Tim to take over and feel free to, share a little bit because I mean, you have an hour, so we could probably fit a whole day for all the work that you're
Yeah.
doing in Illinois. So thank you for being here.
Thank you so much for having me, and thank you for everyone for joining this summit. It is an absolute pleasure to be with you, to spend some time with you today, to talk about kind of what do we do to address some of the barriers to ending the HIV epidemic. And so, as many alluded to, I'm the Director of Government Relations for AIDS Foundation Chicago, where I work as directly on state government policy advocacy work. And this year we were quite successful with a number of initiatives, including a full repeal of the state's law criminalizing people living with HIV, as well as additional money, 15 million for the African American HIV/AIDS Response Fund, in addition to the mandating of 10 state agencies to begin collecting uh, critical demographic data based on sex, age, sexual orientation, gender identity, disability status, and primary preferred language, among some other bills that we were so privileged to work on. And so, as I mentioned, it is an absolute pleasure and a joy to be with you all today. I do want to make sure that you all know that in addition to being the Director of Government Relations for AIDS Foundation, more importantly, I am a person living with HIV for nearly 12 years. And so the work that I do is grounded in that, in my identities as a Black gay man living with HIV. But even more than that, I am a persistent advocate. And this is really an extension of that work. So without further ado, I am going to try to share my screen. Um, let's see here. Hold on just a second, y'all. All righty. Hope everyone can see that. And so the title of this session that I wanted to work on is, are we there yet? Addressing barriers to ending the HIV epidemic. And so I always believe in grounding the conversation and what we're going to talk about today. And of course, there have been, we recently commemorated the 40th anniversary of the beginning of the epidemic earlier this month. And so I want to really ground the conversation on where we are right now and kind of what's ahead of us. And so we know right now, today, we have the tools available to end the HIV epidemic. We have a number of biomedical and scientific research advances that have led to the development of a number of successful treatment regimens and prevention strategies, improved care for people living with HIV. Of course, we're including U equals U, which is we'll be celebrating its fifth birthday or anniversary this year. Undetectable equals untransmittable. Of course, we understand the importance of that, but also pre-exposure prophylaxis and post-exposure prophylaxis, PrEP and PEP. But then also we know that we have syringe service programs at our disposal as well. As 1 in 10 people living with a new diagnosis are through the drug injections. And so we understand the importance of that. And so we know that effective interventions have driven the number of new HIV diagnoses down to approximately 35,000 per year, the lowest level ever. But we understand that recent data shows that we are kind of plateauing on those numbers. Just kind of to go over a bit more, just again, continuing to ground the conversation where we are and kind of next steps. Of course, new CDC data released last month shows that HIV diagnosis fell 8% from 2015 to 2019. New diagnoses among, of course, young gay and bisexual men ages 13 to 24 dropped 33% overall, although we know that African Americans and Hispanics, Latinos continue to be disproportionately impacted. We've seen the uptake of PrEP. 23% of people eligible for PrEP were prescribed, compared to 3% in 2015. And then finally, in 2019, 66% of people living with HIV were virally suppressed, and 81% of people with diagnosed HIV were rapidly linked to care within 1 month of diagnosis, compared to 60 and 75% just 4 short years earlier. But in all of this, this is great news, obviously. Barriers continue to persist in ending the HIV epidemic. And so when I talk about are we there yet, it's I want to share with you all just kind of, I'm a former youth ministry leader. And so each summer, I would take a huge busload of kids ranging from 3 years old to 18 year olds. One, we'd go to the aquarium or to a theme park. And usually every time, 30 minutes onto the road trip, I would have kids, Mr. Tim, are we there yet? And I would tell them, no, we just got on the road. And so 5 minutes later, are we there yet? And then so it would be this kind of thing that until we would get 5 minutes out to our destination, I would say, we're finally here, or we're approaching, and they would get so excited. And so, but we would, I would have to tell them about 20 times, no, we're not there yet. And so I want to spend the next few moments with sharing some client experiences that I have that have been shared with me that illustrate some of the barriers to ending the HIV epidemic. As I share these client experiences, I want you to type in the chat box some of these barriers that stand out to you from these examples. Okay, so with that, I'll start. I had a client that reached out to us that tried to schedule an appointment for behavioral health care. They were dealing with a number of different things: depression, anxiety, from the COVID-19 stay-at-home order, the grieving the loss of their mother, a recent move. It just was a lot of stuff going on with that client. And they were told by a provider that they weren't taking new clients for behavioral health. Now, keep in mind, these are experiences of people living with HIV. And so we have an example of a client coming to an organization, an AIDS service organization, asking for behavioral health care, and was turned away and wasn't even referred to an outside provider. Had another client experience that that they should have received some type of communication from an AIDS service organization that it was time for them to get their 6-month lab done. It'd been 6 months since their last appointment. No one from the AIDS service organization contacted this client till nearly a year after their last lab test. Nearly a year. Another instance, had a client that was experiencing COVID-19 symptoms, including loss of smell and taste. That client was told over the phone that was diagnosed with COVID-19, instructed to quarantine, and to take Tylenol if needed. That client never heard from that AIDS service organization again. Would later find out that there was no mentioning of COVID-19 in that client's medical file. Had another client that went to the pharmacy that's attached to this AIDS service organization, that was told that they had a copay for their HIV medication that would total over $1,000 a month. Now, this client has insurance. And so the client kind of pushed back and said, well, hey, I have insurance. Are you sure? And so, they had never paid that kind of money for their drugs before. The person in the pharmacy, the pharmacy tech, said that they would go, let them look again and they would call them back. So, they called the client back after about 30 minutes or so and found out that they would be able to lower the cost to $750. Well, that client kind of pushed back and said, well, that's still not good enough. Like, I have insurance. There's a thing called Ryan White. There should be something that can be done, because $750 is a lot of money, obviously. And so the pharmacy tech says, well, let me see. And so the pharmacy technician called this client back about an hour and told them that they were able to find programs and whatnot, so that client wouldn't have to pay anything for their medications. Said, okay. There was also a client that shared with me that that the provider was holding their medications hostage. That they would only give the client 3 to 4 days worth of medications to encourage that client to come in for an appointment. And, that client was like, so you're going to hold my medication hostage? Life-saving medication hostage. Also, a client shared with me that the pharmacy technician shared with this client that they were no longer undetectable. Not a provider, not a case manager. The pharmacy technician told this client that. Then finally, I had a client to share with me that an AIDS service organization told this client that they would no longer be doing telehealth appointments, that they would soon be going back to in-person only. And the client shared that they really wanted to continue using telehealth, and that it was helping them tremendously. And but the AIDS service organization did not acquiesce. And so I went to and maybe if Matt, I don't know, I can't see the chat right now because of the display. I'm looking at my screen. Well, I'll tell you what, let me just stop sharing right now.
If you want me, I can read some of the chat.
Yeah, that'd be perfect. What are you all's thoughts? What are some things that went wrong with that? those experiences?
Yeah. So one individual said, barriers that they've seen: long wait times to book appointments. Clients can't get a hold of their case managers for various reasons. Lack of communication between, case managers and medical providers. Another individual said, ASOs focus on HIV or not at all. Many ASOs don't have people working in the roles they need to be employed in. For instance, their current ASO has people employed in like billing department that don't know how to bill insurance or Ryan White effectively. This leads to consumers receiving bills they shouldn't be receiving, and it creates distrust. And then another individual mentioned, so many of these are massive system failures, lack of compassion, thoughtfulness, and then I put lack of providers, lack of provider education, lack of wraparound services and access to wraparound services.
Any other comments on some of the things that stood out to you all as I shared those client experiences with you that just was like, kind of red, alarms, kind of like, what's going on with this? Why did this happen? Any comments that you all want to share? Any thoughts?
Yeah, so there's one comment here, all the scenarios this individual has heard before in an old role that they had. And I think that is where my mind is too. Like, the things you said should be really jarring and surprising, but in the world we live in, the healthcare systems that we live in, it's not as surprising. Like, these are real people who don't have access to the real services that they deserve for whatever reason.
Absolutely.
But the fact that someone went from undetectable to not be undetectable, or they had, medication held hostage, that's insane.
Thank you so much for you all for adding your thoughts and your comments. In full disclosure, I want to let you know that those client experiences are for me. Everything that I just read to you were my own client experiences. Over the past year, all of that happened, everything that I just mentioned happened in 1 year. Astounding. It blows my mind, to be completely honest with you. So when we talk about addressing barriers to ending the HIV epidemic, how do we fix this? I think you mentioned the huge system failures. That is absolutely spot on. Just to share with you about my experience with the pharmacy, when the pharmacy tech finally came back to me and said, Mr. Jackson, you're not going to have to pay anything. Aren't you excited? And I said, nope. And they said, why? You should be excited. We were telling you $1,000. I said, you know why I'm not excited? I said, because I know better. Right? I know. I'm an advocate. I do this, former board president of an AIDS service organization, living with HIV for nearly 12 years. I do this work for a living. So I know. What if that was someone newly diagnosed? And you told them that, incorrectly told them that they were going to have to pay $1,000. You literally would have had someone newly diagnosed walk out of a clinic without the medications that they need to be healthy, to get HIV under control, to get to viral suppression. There's so many things wrong with this whole issue. And so as I started our conversation today with grounding it about all of the great things that have happened, these barriers still persist. and they can't. We're not going to end the HIV epidemic until we begin piece by piece, very thoughtfully, doing the work of fixing some of these issues. It's not that is optional either, to be completely honest with you. We have to. We have to. You know why? Because people's lives are at stake. We have to. There's this old idiom that to adapt or perish. The things that we're doing in HIV, we have to adapt. We have to. The people and communities that we serve aren't single issue communities. They have very complex and nuanced lives. So our response to the HIV epidemic should be complex and nuanced. The top-down approach doesn't work. Doesn't work, hasn't worked, and will never work. And so as we begin taking the steps, and I'm going to highlight some of those in just a moment, how do we go about addressing some of these barriers to care? So I am going to bring my slide back up. And so I could literally have done 20 slides on some of these barriers to ending the HIV epidemic, but I am going to center on 4 of them. Now, granted, these are very expansive, obviously, but they, as I mentioned, are complex and nuanced. And so the first of which is the impact of stigma, criminalization, and discrimination. Of course, we need to talk about how important it is and the impact of intersectional trauma-informed care of people living with or vulnerable to HIV. Then we need to talk about the impact of politics and policy on marginalized communities that are impacted by HIV. And then finally, we need to circle back to the impact of centering communities. And so we're going to start out talking about the impact of stigma, criminalization, and discrimination. We know that there is really kind of a cyclical relationship between stigma and HIV. People who experience stigma and discrimination are marginalized and made vulnerable to HIV. And then people living with HIV are more vulnerable to experiencing stigma and discrimination. Or as we may know, you're damned if you do, damned if you don't. And so being responsive to the work and being responsive to addressing stigma and discrimination requires that we're staying aware and learning the ways that systemic racism impacts the health of our communities. From access to competent providers, to state violence, to ensuring that our community is considered when treating new prescriptions and everything else. All of that matters. All of that matters. Another question, does your ending the HIV epidemic plan include the repeal or modernization of HIV criminalization in your state? If it doesn't, you need to tear it up and start over. Does it include sex work decriminalization? If it doesn't, you need to tear it up and start over. Because we're never going to address the barriers to ending the HIV epidemic until we start removing them. We know how we address HIV. That we do that through HIV testing and treatment. We know that sex work decriminalization and HIV criminalization are barriers to HIV testing. We know this. So we have to remove those. So if you're ending the HIV epidemic plan in your city, your county, your state doesn't include these items and even more, we need to tear those plans up and start over. We cannot end the HIV epidemic if healthcare inequity persists, and we cannot end healthcare inequity without working against systemic racism. You can't do it. Being intentional means that we are thorough in our application of anti-racist frameworks and principles, not just part of the time, but all of the time. Something that we're working on here at AIDS Foundation Chicago is our anti-racist work, our belief and value that racism, systemic racism, is a public health crisis, doesn't shut off at 5 o'clock when I close this computer. You know why? Because people living with HIV don't get to, they don't stop being, living with HIV or being vulnerable to HIV at 5 o'clock. Black, Latinx, Indigenous, LGBTQ communities don't stop being impacted at 5 o'clock. And so our work in anti-racism can't stop at 5 o'clock either. That means it must be a part of everything that we do. Everything. Those most at risk to HIV continue to face stigma and discrimination based on their actual or perceived health status, race, socioeconomic status, age, sex, sexual orientation, or gender identity, or other grounds. We know this. And so, how do we go about addressing these barriers to ending the HIV epidemic? Is about understanding the impact that stigma, criminalization, and discrimination have on the communities that are impacted. And so if we're not doing some of these type of things, that we're not talking about addressing stigma or talking about HIV criminalization, if we're not talking about any of those, then we've already lost. I say oftentimes, we could literally put $3 trillion in an HIV plan. And if we aren't addressing stigma, it is all for naught. And this is not new. This is not earth shattering. This is not, breaking news. We know this. My mom used to tell me all the time, when you know better, you do better. We know better. We just have to start doing better. And we have to do that by facing stigma, criminalization, and discrimination head on. The next one, impact of intersectional trauma-informed care of people living with or vulnerable to HIV. We see this in access to care. Are we linking people immediately to care? Immediately. I'm not talking about 2 weeks or a month. I remember being on a call about a year ago, and I had one organization on this call that I was on, and they were happy that they were linking people to care within 30 days. And I was like, have you lost your mind? That's nothing to be proud of. Immediately. Are we including people with access to PrEP and removing the barriers that we see with access to PrEP, i.e. cost? Are we using U equals U? If we have prevention programs, or just talking about treatment as prevention, and we aren't using U equals U, what are we doing? As I mentioned, as I said earlier, we have to reject the top-down, one-size-fits-all models of healthcare delivery, especially in the HIV space. It doesn't work, hasn't worked, and will never work. That's not how you address health disparities. If you're running the same prevention programs for Black cisgender women that you have for Latinx trans women, you can't be shocked when it doesn't work. Again, this is not earth-shattering. You can't use the same interventions for young people that you use for long-term survivors. Again, we have to be complex and nuanced in our interventions, because the people and communities we serve are complex and nuanced. How are your quality measures when it comes to client satisfaction, medication adherence, viral suppression? What are those numbers looking like? How do you use telehealth? Do you have teleprep services? Are you working on legislation in your state that allows pharmacists to prescribe PrEP and PEP? These are some of the conversations that you need to be having. Because again, we're about removing barriers. That's how we get more people tested, more people into treatment. Is it to make it easier? So you remove everything that could potentially stand in the way. Are you training your providers, case managers, and front end staff the importance of cultural competency and cultural humility? Is implicit bias training provided? It's huge. We were able to work AFC with the Illinois Legislative Black Caucus on historic legislation that will now include a mandate for implicit bias training for every provider in the state of Illinois. Because you can't address healthcare disparities, racial health disparities, if you aren't providing these type of trainings. Again, when you know better, you do better. What does your prevention, education, and outreach look like? Are you using the same tired prevention strategies that you were using 10 years ago? You have to change it up. You have to. You know what we've seen in the HIV space is a lot of trying to force a square peg into a round hole. We have to reject the complacency, the notion of, well, we've always done it this way. It doesn't make it right. You could have always done it this way for 20 years and it been wrong. That's completely the definition of insanity to me. Doing the same thing over and over and expecting a different result. How do we fix this? First of all, stop creating programs without centering community. I will tell you, as I share with you, I am a Black gay man. I know the experiences of being a Black gay man. I don't know the experiences of being a Black trans woman or someone who injects drugs. I don't have those experiences. And so I can't create programs or lead programs, and I am not affected or impacted by those. That I don't share those experiences. And so, the question is, well, I had someone during a talk, well, we don't have any trans people, at our agency. Well, that's a bigger issue. Because if our agencies, if our clinics are not representative of the people we're serving, what are we doing? What are we doing? Like seriously, front end staff. And I'm not just talking about the token positions of peer navigators. I'm talking about case managers. I'm talking about directors and senior managers. I'm talking about senior leadership team. I'm talking about boards of directors. Because that's how you affect change. It's about centering community. That's how you change these healthcare delivery models and really just turn them upside down. It's because the needs of one community aren't going to be the same needs for another community. But yet our response has typically been, this is our model. There's no nuance, there's no complexity in it. Again, the people and communities we serve are not single issue people or community. They're complex, they're nuanced. And so our response should mirror that. The next one is impact politics and policy on marginalized communities. We understand that most 501c3 nonprofit organizations have to walk a very thin line when it comes to politics. I understand that. There are some things that you can and you cannot do based on federal law, specifically tax law, that of course affects your tax designation as an organization. And so that's important to realize. That's a real thing. I get that. But it doesn't say being a 501c3 that you can't organize. Doesn't say that. Doesn't say that you can't hire a lobbyist. And you have to understand why it's important that we do this work. Because the lives of the clients and the communities that we serve are at stake. Right now, we are seeing around the country, state legislatures are continuing to advance bills targeting trans, gender, and non-binary people, including criminalizing healthcare for transgender youth, barring access to the use of appropriate restrooms, restricting their ability to fully participate in school sports, allowing religiously motivated discrimination, and making it more difficult to get ID documents with their correct name and gender. Something as simple as getting an ID. There are barriers. And you say, well, why is that important? Well, how do you access services? You go into a doctor's office, they're going to ask you for your ID. If you're trying to get housing, they're going to ask you for your ID. If you're trying to drive to your appointment, you need a driver's license. And so that's why that's important. We've seen courts overturning the vote of the people to expand Medicaid in Missouri. We see cities and states shuttering the doors of syringe service programs, even though we know they're widely effective. We know this. And so, sure, we have national organizations like AIDS United, NMAC, Positive Women's Network USA that are doing great work when it comes to HIV policy on the federal level. But y'all, they can't do this by themselves. You know why? Because community matters. NMAC, AIDS United are based out of DC. They don't know what's going on in Chicago, Illinois. They don't know what's going on in Columbus, Ohio, or across these 50 states and District of Columbia and our territories. They don't know. They don't know like we know. We know that the government closest to people living with or vulnerable to HIV, the mayors, the city councils, state legislatures, governors, those are the ones that are directly impacting the daily lives of our clients. We cannot be afraid to get into the arena. We can't be afraid to organize for what we want. Because if we don't, we're going to be left behind. We're going to be left behind. And then we're going to be on the defense trying to defend these despicable actions of these state legislators. And so our advocacy should extend past the annual advocacy day at the state capitol or AIDS Watch. Our advocacy should continue, should be heard every time the doors of the City Hall, the State House, and Capitol Hill are open. We can't continue to wait for others to advocate for us. The time is now. We are the ones we've been waiting for. I don't know about you, but I don't feel like waiting another 40 years to end the HIV epidemic. I don't feel like waiting, and I don't think that you do too. You do either. Finally, and most importantly, the impact of centering communities. Community-centered engagement means that a service organization, community-based organization, boards of directors reflect the communities impacted by HIV. They have to. And I'm not talking about, oh, well, I have a Black, a Latino, and I have a trans woman on our board of 20. That's not representation. That's not community-centered engagement. That's tokenism. That's checking the box. That's not the way this works. Community-centered engagement means that everything that an ASO or CBO does is rooted in community. Everything. From communications to our prevention strategies, our programs and services, everything. Everything. Meaning communications. If I am doing a program to increase PrEP uptake for cisgender Black women, and there are no cisgender Black women involved in the creation of these communications and are in the actual communication, whether it be an article, whether it's a flyer, whether it is a billboard, or a television commercial, or what have you, what are we doing? What are we doing? It's not going to work. And then we're surprised when it doesn't work. Well, that's why, because you're not centering community. What does meaningful engagement look like? In the HIV space, we talk about meaningful engagement of people living with HIV, the Denver principles, the importance of self-empowerment. What does that meaningful engagement look like? Community centering community means involving the impacted communities from the ideation stage. But oftentimes, community engagement happens as an afterthought. You've already put the program together, and let me run it past my consumer advisory board, just to check the box that we've talked. That's not the way this works. Priorities will change, even in similar broader issues like HIV. For example, what Black and Latinx men who have sex with men prioritize is remarkably different than what Black cisgender women, Black trans women, sex workers, or people who inject drugs prioritize as important. There's beauty in these differences. Again, I come back to complexity and nuance. Community-centered engagement is more than a consumer advisory board, a meal, and a $20 gift card. And while I am at it, if you have something called a consumer advisory board, first of all, I need for you to change the name. I put this on here specifically, so I would remember to say this. Consumer means that the people that make up this board are only taking away from. But we know that's not true. They're adding value. They're sharing their experiences, their thoughts, their concerns. And so there's not a consumer advisory board. If we have to call it anything, because I know in the HIV space, we love our acronyms, our alphabet soup. Community advisory board, or come up with a completely different name altogether, brand it. Again, something different. But that engagement looks more than just a meal, some dry pizza or some chicken tenders, and a $20 gift card. I also want to hit on that it's not enough just to be community centered, but it must be community led. It has to be. I say oftentimes that there are some people working in the HIV space that have misplaced their tambourine, meaning it's time to step aside. Because a lot of times, the communities most impacted aren't the ones making the decisions. They're not even involved in the decision-making process. And so that's how we go about centering communities and making sure that we're doing this in a very thoughtful and engaging way. I want to end on this, that community-centered engagement is ongoing and involves reassessing who's at the table, who is missing, and have our priorities changed. This is constant. This is not a one-time thing. This is not, well, we met in March of 2021, and now it's December, and we've not done a reevaluation of who's missing from this table, what voice, what experiences are missing from this table. There is always room at the table. That's how you center communities. As I close, I do want to mention that the communities that we serve are often disrespected, disinvested in, and disregarded by society. We can't allow that to continue to be the norm when they walk into our clinics and organizations. We have to treat people with the dignity and respect, providing them the healthcare and support services they need and deserve. To have a positive impact on our communities and to end the HIV epidemic, we must address the devastating impact of stigma, criminalization, and discrimination on people living with or vulnerable to HIV. We must transform our healthcare delivery systems to models that are trauma-informed, intersectional, and rooted in racial health equity. Third, we can no longer sit on the sidelines waiting for others to advocate on our behalf. We are the ones we've been waiting for. Fourth, we must agree that without a doubt that systemic racism is a public health crisis that has a deleterious impact on the communities we serve. Finally, we must be community focused, community centered, and community led in everything we do, in the boardroom, the waiting room, the break room, and the exam room. When we address these barriers, when we work together, when we amplify the voices of the communities most impacted by HIV, we can finally answer yes to that age-old question. Are we there yet? And so with that, I close and wanted to see if there are any questions.
Thank you, Tim. That was very enlightening in so many ways. And it really shows the expertise that you have brought to, the area that you're in Illinois and Chicago. But the work that you're doing in Illinois and Chicago is not just for that area.
No.
It's universal across all any of the epidemic jurisdictions, states, countries. It's really important. And there's a lot of praise in the chat from a lot of the things that you have stated. Everything from agencies not employing folks that are part of the communities that they are trying to serve, to understanding the healthcare system's broken.
Yes.
But people keep voting to keep it in place. So with that, one of the questions in the chat is, and you kind of alluded to this, or you kind of mentioned this in the previous couple slides, but how do ASOs and others expect to bring consumer advocates to the table to end the epidemic?
Being very thoughtful and intentional. And this is what I mean. Before I moved to Illinois, I was the board president of Thrive Alabama. It's an AIDS service organization providing care to people living with HIV across 12 counties of North Alabama. And so we set out intentionally to talk to our clients. And it was literally all hands on deck. That it was constantly, that it wasn't just enough for our board of directors to be involved, but our senior leadership team was involved. Our case managers were involved because we wanted to make sure that everything that we did represented, one, what was from community, two, that community was involved from the very beginning. I cannot tell you how many times as board president, I said, we are stopping what we are doing right now until we bring in this community, this community, this community. I will tell you, I cannot tell you how many eyes, roll at me, the deep sighs, I don't care. People's lives are at stake. And so when we do this work, we have to make sure that everybody is there, because that's, to be completely honest with you, that's the only way we're going to end the HIV epidemic. We can't keep relying on, the good old days of the advocacy from the 80s and 90s. I am so completely appreciative of that work. But it's a different time. The communities that are impacted are different than it was then. And so we have to be very thoughtful and engaging on exactly what that looks like. And so to my point earlier, that means having more than one or two people on your board that are clients. No, that's not the way this works. And the thing about it is, what is interesting is a lot of AIDS service organizations, community-based organizations, are becoming FQHCs. Well, by federal law, rules and regulations, is the FQHC, your board of directors has to reflect the people that you serve. And so I think if we begin making that the norm for aid service organizations, begin normalizing that practice, I think we can really start seeing a remarkable difference in engaging community and being very thoughtful and intentional about it.
Yes, that's an important piece too. I think what you just highlighted with the FQHC statuses. And there's certain expectations and stipulations that come along with that, which sometimes often gets lost in the mix. So right now, I don't see any other questions that are in the chat, but there is a lot of praise about the fact that people are missing from the table, from the discussions. Decisions are being made for us without us. It's really, it's mind-blowing to see these things happening and unfolding right before our eyes.
It really is, because it's astounding that we know that there are a number of communities that are impacted disproportionately so by HIV. Yet time after time, we go into boardrooms or meeting rooms or what have you, to where these communities aren't reflected, aren't sitting at the table. And the beauty of having all of these communities represented is that, yes, it's diverse. There's diversity of when you talk about color and sexual orientation and gender identity but it's also diversity of lived experiences, right? There's also diversity of thought. As I mentioned earlier, we're not all single issue. We don't all think the same. I am from the South, and as I mentioned earlier, that I believe in my Southern colloquialism. There are more than one way to skin a cat. There are more than one way to do things, and that's okay. And so, but you don't get to that point if everyone is not at the table. And so, what we have to do, we have to start demanding. Scoot over. If you have to bring a pallet, if you have to bring a folding table, that's what Shirley Chisholm said, the great Congresswoman, Shirley Chisholm. Talking about bring you a folding chair. Because there's always room at the table. Always. And so we have to be very thoughtful and engaging in that and realizing in everything we do, everything is community centered, and are they leading in this? Because I want to leave you with this. As I mentioned earlier, I was a former youth ministry leader. And prior to me becoming youth ministry leader, my pastor told me, he was like, well, Tim, we plan these programs, and the kids don't show up, and specifically our teens. And I was like, are you involving them when you're planning these programs? Well, no, we're the leaders. I said, are you asking them what they want? No. I was like, well, how do you expect them to buy in and want to do it? So one of the first things I did as a youth ministry leader, and I think this applies also in the HIV space, I did a quick little survey. I said, what do you want to do? And literally, and they thought that it was just going to stay there. Well, no, what I did, I went and took everything that they said, and I went and made it into a 24 by 36 sign that hung on the wall on our youth ministry wing of the church. And every time we did something that they wanted to do, I went and marked it off. And so we went from having about 5 to 6 teens showing up for our events to having 75 to 80 teens showing up for our event, because it was something they planned, they wanted to do. It impacts them. I'm not a teen. I have a hard time doing Facebook and Twitter. Like, I don't know how to do no TikTok. I don't know how to do any of that. But I allowed them to lead. I allowed them to lead the discussion, to be centered. And it's the same thing in the HIV space. When you allow people to be centered, the people that are most impacted by the work that we do, you'll be amazed at the results. And so I'll just leave it there. I have added this slide as my contact information. Please feel free to reach out to me. Phone, text, there's my email as well, tjackson@hchicago.org. If you are on social media, please feel free to reach out to me, Facebook, Instagram, Twitter. I'm on LinkedIn too, but forgot to add that one on here. Please feel free to reach out to me, friend me, some, what have you. I'd love to engage with you all. And as I close, again, thank you all so much for this invitation to spend some time and share some thoughts with you. And so I'll turn it back over to Matt.
Yes, and thank you so much. Again, this has been incredible plenary. This has been an incredible just content to soak in and to sit with. Especially as we all work on our ending the epidemic plans, we all implement those plans,
Yeah.
We all are out in the community doing work each and every day, whether you are getting paid to work in the field or you are just being an advocate or an activist and making a major impact that way. This information is vital. Making sure people have a seat at the table, making sure they are the ones at the table making the plans, and not just sitting there and just having to be a number to hit your objectives, like they're actually engaged. So thank you, Tim. And again, his information is available on the screen. You can also go to the speakers section of the conference platform, and you can view there as well Tim's information and reach out that way. So, but thank you, Tim. I really appreciate you being here.
You're more than welcome. It looks like I just saw Brian Jones raise his hand.
Oh, let me see if he is still, there he is.
My buddy, Brian, how are you? You're on mute.
I was really just applauding you. And that was the whole thing, just letting you know, I'm here for it. I hear you. What you're saying is what I'm saying. And hearing that, I never had the depth of where you sat. You know what I mean?
Yeah.
When I realized that you may be kind and you may talk kind, but the work is not kind. And that's what I appreciate.
No, it is not. I will tell you, thank you so much for that. I truly value our friendship. But yeah, people, they're like, Tim, you're kind of like a dog with a bone. And I was like, yeah,
I know you
I
get
am.
in the room, you like in Hamilton.
Yeah.
I want to be in the room when it happens. We don't even know you're in the room, but it happens because you're in the room.
So, but yeah, I've only been in Illinois for a little over a year. And I have been, when anything HIV/AIDS related comes up, my phone rings.
But let me get off here, because they're gonna say, they're gonna use my pronoun and say that, why is he on there? Ask yourself why not. Okay.
Hey, and I'm gonna reach out to you about something I want to do for HIV decrim. So
okay, no problem.
Thank you, Brian.
Thank you,
Tim.
both.
We'll move into our closing here, and to highlight Positive Impact really would not have happened without the work of our organizing committee. So I wanted to give shout out to Jane Russell, David Andrus, Jan Stockton, Gloria Augusto, S.J. Harden, and Lauren Braymeyer. They have all been crucial in consulting with me and to work with me on this event. I could not be more excited to work with such a great group of people. And they were also instrumental in bringing a lot of the speakers into working with a lot of the folks that we have had speak throughout the summit. Also wanted to highlight sponsors of the summit and giving contributions from Gilead, Equitas Health, Midwest AIDS Education and Training Center, and then Vive Healthcare. I also wanted to highlight a couple of events that are coming up for people living with HIV in Ohio. We have a program called Life Plus. It is a weekend retreat in September. The retreat, which some of you I see on the plenary here have been to past retreats, but they really focus on wellness. And this year, the theme is connection, education, and relaxation. So check out equitashealthinstitute.com in order to check out the information. And then we also, in October, we have our Transforming Care Conference, which is our conference on LGBTQ plus and HIV health equity. It's October 13th and 15th. This year will be at the Fawcett Center at The Ohio State University. Also, we're looking at some hybrid approaches. So check out equitashealthinstitute.com, or you can go to transformingcareconference.org, and it will take you directly to the conference information. Registration will be open soon, and we do have a call for abstracts out. So feel free to check that out. If you have any questions, feel free to reach out to us. You can find my contact information in the speaker and organizing information in the conference platform. So you can reach out to me directly, or if you have my information, as most of you do, feel free to reach out to me directly. But thank you again to everyone for making this possible. And I hope to see you in the future with other events that we will have. Thank you.